We're going to get started. So we are on to our second panel. So I'm going to let my panelists introduce themselves. The exception, I suppose, is that I demanded Casey be on both panels because she's a pharmacist and they are so few and far between in this world. So Casey is back with us again. Morgan.
No.
Is it on? It's on the top.
Okay, now it's on. I'm Morgan Younkin. I work at Healthcare for the Homeless in Boston, where I'm Med Director for Harm Reduction Services.
Hi, it works. So, and I'm Terechin. I'm a psychiatrist, and my clinical work is at the Brigham Women's Bridge Clinic, and I also do research with Jaji Suzuki Lab, and I'm a representative from Massachusetts Psychiatric Society to American Psychiatric Association, where I do my advocacy work.
Cool. I'm Liz Quinn. I'm a family and addiction medicine doctor at Lynn Community Health Center.
Alrighty, everybody. So we are going to jump into our next case, and I will tell you it's a doozy. So we have a 44-year-old female with severe opioid use disorder. She has had many trials of MOUD over the years, currently using fentanyl 4 to 5 grams IV daily, severe cocaine use disorder, tobacco use disorder, moderate persistent asthma, untreated hep C, though not cirrhotic, major depression, generalized anxiety disorder, and PTSD, who presents to the hospital for a large right forearm ulcerating skin wound for the past 3 weeks. She reports poor appetite for years and says she's lost a lot of weight in the past year. Her current BMI is 10. Her usual weight in clinic has been 46 kilos. Here she is 25 kilos on admission to the hospital. She lives in a rented room. She really has no social support due to her years of ongoing SUD, like very impressively isolated in the community and really not engaged in primary care at all, is sort of like ostensibly a patient of our clinic due to maybe an urgent care visit or something like that. And she, after obviously came into the hospital with this large right forearm ulcer and is currently reporting significant withdrawal symptoms and 10 out of 10 pain in her arm. She's received Tylenol and IV Toradol without any improvement. And so you are being called to provide some helpful recommendations. So turn to your buddy and take 60 seconds. What do you do for this lady?
Yeah. My
Oh, that was better. All right, I'm gonna flip it to our panelists. Morgan, I'll kick it to you.
Hear me now? No. Yes, you can. She needs an opioid agonist for treatment of pain and withdrawal. So I think that's pretty clear. She's got pain that would be indicated for her. She's in a controlled setting. We can safely monitor this. Then you get into questions of dosing. But I mean, you're in a hospital, so you can use whatever tool you want. But I think that's the, and she needs probably quite high doses, or at least higher than what she's been given so far.
Olga, any thoughts?
Yeah. So I just wanted to point out, the patient comes in when she absolutely has to. So she's quite ill in the community, right? Like she's very malnourished and she's not like help seeking. A lot of patients we see when they present like that, but a lot of the anticipated stigma. So it's like, I would say that just keep in mind the withdrawal. I had to search like how to convert 5 milligrams of fentanyl into anything like you can legally prescribe, right? So she has extremely high tolerance for opioids and has an extremely large and painful wound. And so we have to like take into account withdrawal management plus the pain management, and plus that the patients will feel rejected if we're not proactive about it. And if they're gonna feel like they have to ask and they have to like beg for those medications, for someone who's not engaging in treatment unless she has to, she can just leave.
Liz?
So I think the pharmacological answer here was the, obvious one. I'll just add that like that profile of patient where it's someone who hasn't engaged in regular care, is not really tied in. This is our opportunity to make a positive connection. And one thing that our health system struggles with is that if one person makes that positive connection in the hospital, that doesn't necessarily translate to that person having a positive connection with outpatient care unless we intentionally build that system. So you want to start thinking about, well, what's the system if you're meeting someone like this in the acute care setting, what's the kind of functioning system to help whatever positive interaction occurs to then bridge into outpatient care so that this person can get her Hep C treated and can kind of get the primary care that she needs.
Can I build off of what Liz was saying? I think, so in this study, she's in the emergency department, she's miserable, she's probably depressed. She's been that way a long time. The ED is a miserable place to be. And I think like focusing on like, what is her immediate felt need right now? And then giving something extremely concrete and tangible to her, the withdrawal management, and like really focusing on that as a gesture of goodwill, and that is a demonstration of kindness and respect that's more important probably than the words we say. And then I think the other piece too is she's probably got xylazine withdrawal going on that we're not treating. And then just looking into her psychiatric comorbidities, looking into benzo use as well. And so withdrawal from non-opioid substances could be playing a role.
All right, so the case continues. Addiction medicine gets in there. They see her pretty quickly. She gets a 1 milligram IV push of hydromorphone, doesn't do anything. 2 milligram IV push of hydromorphone doesn't really do anything. She gets started on some methadone. She gets 20, and then she gets a 10 PRN times 2 doses the first day. And she gets some 2 milligram hydromorphone pushes as well. Maybe it helps a little bit. Part of the problem is that the patient is frequently relatively sedated. Potentially to Morgan's point, there's maybe interaction of other substances. We know she has a really severe stimulant use disorder, and she's probably coming off of that. She's also so malnourished, right? And so like her metabolism and like pharmacokinetic stuff that's happening, right, like is probably really challenging to predict. And she also just chronically is very hypotensive. And it's a little bit unclear because we don't really have a lot of data points, right? She's not been admitted to us before. We don't have a sense of what her norm is. Is she septic and we're sort of not managing that? Or is she just always hypotensive because she's very malnourished? She has poor oncotic pressure. And so that first sort of, few hours of interaction, the ability to titrate her full agonist is really pretty hampered by her picture. She does get some imaging, surgery sees her. They agree that they think this is likely a xylazine related wound and that she's probably got superinfection of the wound with a bacteria of some sort. And on day 2, she requested to leave the hospital because she really felt like you clowns are just like not doing the right thing for me. Which frankly, we weren't, right? And so how do we handle that? She wants to leave.
With that treatment, maybe.
I haven't done hospital medicine in 10 years. So I'm just gonna say that, but the number one first thing out of your mouth when you get the call of this patient's going to leave is, it is 100% your right to choose to leave. And just like affirming out loud the autonomy of that choice so that this person doesn't feel trapped. And then exploring just I'm gonna say the banned words, harm reduction approach in the book of like, what can we, if you're choosing to leave, how do you think we can help you to be as safe as possible in the community? What does that look like for you? So, I think that would be kind of the two things I would bring to the initial conversation. If we were able to find a way with appropriate monitoring, because we were in an inpatient setting, up titrating her methadone faster, than what was done, could have helped her to feel a little bit less uncomfortable sooner. But I know that the sedation was challenging.
In a sense, where I work at the Bridge Clinic and we do like questionable prescriptions like all the time, where I just have, there are a lot of like, and for me, that patients in inpatient settings who have telemetry, who have pulse oximetry, like it's like a dream for the Bridge Clinic provider. Sometimes I send them home and say, hey, tell someone like that we doing that med change, make sure they have 2 Narcans ready, and let's hope for it. And here it's like it's a safe place and like pushing that sedation a little bit. And also what I was reading that preparing myself for the case, this is where I think like the peer specialist might be a good place to introduce like what are you actually going through from a peer-to-peer specialist like a recovery coach, and having them available in the hospital setting.
Yeah, I think you bring up a really good point about in a hospitalized, highly monitored setting, like what is safety, right? It seems like everyone's concerned about the blood pressure. People are concerned about the patient maybe not responding to our interactions. Is that sedation? Is that a behavioral response? Is that misery? It's hard to say, but I think the rubber meets the road with opioids in terms of respiratory depression. And so I really specifically here, we should be looking at the respiratory rate. And if the respiratory rate's maintained, if the SATs are maintained, then we have some room to go on opioid agonists if that's what the patient needs. And you're in a hospital, so you have your whole, you can use short acting, you can use long acting, you can use spot this as a methadone. But I think going back to what Liz is saying about affirming to the patient, look, you've made the choice to stay here so far. What's the thing that's been driving that? And like, how are you feeling now and what's changed? And just really affirming to them that like they have stayed in the hospital for a day or 2. And so they have been continuously making that choice to seek some sort of healing. And then to kind of pose that question to them once again now, maybe why that's changing, what that means for them. And then if they want to leave the hospital, then let's get creative about what follow-up looks like. Because most of my job is like the patient has left the hospital and is now, we're seeing them on the street or in a clinic. And how can we kind of continue to creatively help the patient get done what they want done?
What discharge prescriptions do you send her with? It's got the dirtiest looks from my panel, y'all. Like, do you send her an opioid?
You have to. I mean, with how much she's using and injecting, that would require transportation to get there every day, though. Oh, okay.
Yeah, I mean, maybe this patient is relative, I would say at best ambivalent on the subject of buprenorphine or methadone. She reports maybe that methadone's worked better for her, but transportation, she lives on a 3rd floor walk up, she can't get around.
For home with a short acting full agonist personally. Yeah, I don't think that would be safe.
I think in this particular, and to preface this patient, makes me very sad. This is actually the reason why I got interested in all of this and being a part of the pain task force and all of that. Just with regards to insurance coverage and just, seeing that as a huge barrier. But in this particular patient, I mean, I feel like there's no question that she needs some sort of pain management. It most likely is going to have to be an opioid agonist. And then just making sure that we are removing every possible barrier that we can think of, whether it's filling at the pharmacy because of, pharmacist concerns for safety, whether it's insurance coverage concerns, sending those scripts early, calling the pharmacy ahead of time. I know it's extra steps, it's a lot, but if you have me, I'll call for you. But really just, doing all of those things so that when the patient does, decide to leave on her own, those scripts are there and they're ready so that, hopefully that can be one less barrier for, she obviously is going to need some sort of antibiotics as well.
Anyone here not comfortable sending this patient with antibiotics? Like, please send her with antibiotics, right? Good, great.
Take some.
Yeah. Sort of, like on the books she does, but she's not engaged in a meaningful way. Okay, so we're gonna fast forward a little bit. So over the next 2 months, this patient is actually admitted to our hospital really every few days. She generally has a self-directed discharge due to inadequately treated pain and withdrawal after 1 to 3 days. Her wound continues to worsen during this time. No concern for osteo, but she does have ongoing weight loss. Addiction medicine is a little bit hampered. They're pretty new in our hospital at the time. And there's a lot of hospital confusion regarding safety and legality of methadone dosing and titration in the hospital. And so even though addiction medicine feels very strongly that they would like to titrate this patient faster, they're actually kind of hamstrung a little bit in how fast they can go. And there is not a ton of comfort among nursing and clinician staff of continuing to dose opioids in a patient who appears sedated. Like that is just not something they're used to yet. And we really haven't even at this point figured out like what a capturing dose of opioids for her would be. She'll often get 6 milligram IV pushes of hydromorphone and faster methadone titrations, and they're kind of like just like not really doing anything for her at all, which prompts her leaving. And she does sort of, over this, say 2-month period, she does start to express actually that she thinks she maybe would like to be engaged with an OTP to continue on methadone. And there's been some benefit to her, especially as we're starting to get her titrated faster when she comes in. But she has no transportation, can't keep her hands on a phone really whatsoever. And it really is just quite tough for her. So I'm going to continue actually to the next part of the case because it gets really good. And so this sort of continues, this cadence continues for ongoing months where really she's there just every few days. And addiction medicine has really grown sort of thanks to this particular patient in terms of methadone titration. And so they've been more successful at getting her to 90 to 100 milligrams quite rapidly, just in the first few days, with some hydromorphone IV pushes for pain. She's been really more able to stay awake in the hospital and is now really able to stay in the hospital for 4 to 5 days before choosing to leave from ongoing withdrawal symptoms, as opposed to like 1 to 2 days. She's frustrated that the pace of medical care is slow, right? And she sort of is feeling a lot of urgency to get her help together. And then she comes in on a Saturday and it's a holiday weekend and like nobody seems to work at this hospital on weekends. Like, where is everybody, right? And obviously, she has major depression, she has generalized anxiety disorder, severe PTSD, and those are really at the forefront for her during her admissions. During this time, her arm ulcer is pretty unchanged. She's getting wound care while she's here in the hospital, but not really when she leaves. And she's continued to inject into the area. She's had, a bunch of antibiotics thrown at her over the period. And newly is reporting back and hip pain. And she actually gets diagnosed with an L5 pars fracture. She's not an operative candidate, really due to malnutrition more than her use. Surgery says, you know, this lady's BMI is 10. Like we can't bring her to the OR, right? Like this is just not gonna happen. And imaging sort of that when the fracture is diagnosed, imaging comments really that her bone density actually looks very dramatically decreased, likely secondary to her malnutrition. So now she's here, she's got this fracture. You've managed to get her to say 100 milligrams of methadone and you're giving her some IV hydromorphone. What are next steps for her? How do we keep her?
How does she get to the hospital? Is she arriving because she's found down and she's in an ambulance and that's how she ends up at your door? Or is this someone who's making a choice to come in when she comes in? Okay. And has someone had a conversation with this duo about their choice of hospital? And I'm saying this 100%. I'm saying, sorry. Because this is the guidance I give people, having struggled through working at a community hospital where we didn't have robust addiction supports, and it is improving and we are working on it. But when we would start to see this pattern, you have the conversation and you say, I don't think you can get the help that you need here. And we do that for people if they need a specialist at a tertiary care facility. So if we don't have the specialist, and that's not how it should be, obviously, we want our community hospitals to be able to up titrate someone on methadone rapidly while they're inpatient, particularly if these are complex community hospitals that have trauma and ICU services. But if they're not doing it from this individual patient's perspective, the conversation I would have is, you know, my recommendation to you would be that you go to either Boston Medical Center or Mass General. If you're making a choice to do that, I'm going to call down and talk to my pals there, and we're going to try to make sure you get treated well once you're there. And I think it sounds like things got better over the course of her experience, but I think, you know, from an individual standpoint, with the ways that our systems are broken, our individual patients, like, they don't have the privilege of waiting for us to fix all of the systems we need to fix. So that would be one conversation I would have. And then the other, if she and the friend are kind of making a choice to present to care, then digging further into the conversation Morgan was having about, wow, you're making a choice to be here. You're making a choice to then stay here for 4 to 5 days. What's that about? You know, where's the motivation? What is it that we have done that has worked for you? And really trying to build on that.
Other thoughts? How do we get her to stay?
I'll repeat myself with that, the recovery coach, peer specialist, social worker, because she sounds like spends a lot of time in the hospital, in and out, and probably build some relationship, and having more of those like kind of psychologically oriented conversations about like what does it mean for you to come? What does it mean for you to leave? We've heard all types of stories, and sometimes people have like paths and they need to go back and no one asks them, this is why they leave. So just kind of like, what's the meaning of leaving? And another question that was just as we were talking about the part where she was in and out of the hospital, was there cows like part of the picture? Was there a withdrawal, or when we say like 6 milligrams didn't touch the pain, or didn't touch the withdrawal, was it covered in goosebumps?
Really the pain. So we finally sort of gotten to a point where she wasn't so much scoring on cows for objective things anymore. She didn't appear to be physically unwell from opioid withdrawal. It was really pain at this point. She certainly would talk about cravings and some, maybe worsened anxiety. Like, I think there was a bit of withdrawal at play, but it was really more pain at this point.
And another thing which crosses mind, like this is a lot of time spent in the hospital, right? And hospitals are like not the best place to be in terms of like, as you cannot sleep, it's noisy and it's boring, right? So it's like, how is she doing from that? Like, did someone ask her, it's like, how does it feel to stay in the hospital for that long?
I mean, at this point in the case, I think her addiction is starting to be treated. Her pain is starting to be treated. You kind of keep going down along those has. You keep working with her on her goals. I had been thinking earlier in the case, like when she's in this cycle of these really short hospital touches and then back out into the community, you wonder like, what does community-based engagement there mean? Or like, how do you somehow leverage that perceived need for healing that she's presenting to the hospital? How do you make a connection to an outpatient team? And that can feel like this a difficult cycle. Going back to your question about, do you discharge her with Dilaudid at that point in time when you're not even capturing her pain with IV Dilaudid? You know, I think there is a case to be made that you can treat acute pain with an opioid analgesic in a short course to engage the patient to treat their pain and to help incentivize outpatient follow-up. It gets fraught though, because then the person seeing them then has that thing that they've already been promised. But I do think it's really worth thinking about, what does trust, what does engagement, and what does taking the patient's perceived and articulated main concern seriously mean, and how do all those things interact with each other and inform what we're willing or not willing to prescribe.
It also sort of seems to that point, Morgan, like if you were going to discharge her, say, with a course of oral hydromorphone for acute pain because of this new fracture, like we can't even really capture her pain with like high doses of IV plus a whole bunch of methadone, right? So like, how are we gonna, you know, poor Casey's gonna have an aneurysm if I'm writing for like 500 tablets, 1 day supply of Dilaudid, right? Like it's just sort of, you know, it would be a shot in the dark at best, right? And I don't, you know, on the like, could that help to engage this person? Like, I don't know, she's getting plenty of Dilaudid while she's in the hospital. It doesn't seem like that's the thing she's missing in her life right now, you know? And so I sort of even wonder, like, would it even if we were saying like, okay, we're gonna, you know, be a little bit sketchy in our approach to this patient and like a real goal of helping to engage her in care, like, I don't even know that it would work, right? There was a question down here. I'll repeat it. Yeah, so that question was really fantastic. It was, what is the purpose of keeping her in the hospital? Is it that ID has said she needs 6 weeks of IV antibiotics, or ortho has said she needs a surgery, or we're just sort of overall trying to stabilize her? And it's such a good question, right? Because thus far, like, does she really have a criteria for hospital admission? You know, like sort of, I guess, but like kind of not really. And I actually think a little bit of the issue is that because the pace of hospital medicine is so slow, she's sort of like never had a complete workup of all the things to determine that she doesn't need to be in the hospital anymore, right? Like, you know, I'm sure there was like a pending echo that never happened to make sure she didn't have endocarditis. And you know what I mean? Like, because the hospital stays have been so abbreviated, we sort of haven't even been able to arrive at the conclusion that, oh, in fact, you could totally just be fine in the community if we could get you VNA with wound care, who also could bring you like a methadone dose, right? Because like that, like, what are we doing? We're doing like wound care, pain control, which we're doing a terrible job of. Nutrition, right? And, you know, could you argue that somebody with a body weight of 25 kilos is a reason for admission just for nutritional support? Yeah, I think so. But I really appreciate that question, because I don't know that like on paper she's really got like a reason to be in the hospital even.
Agree.
Oh, Casey, tell me.
I disagree. From seeing those photos of,
Yeah, I mean, the wound is really bad. Yeah, the wound is really bad, and you know, she's got a new fracture and all of this. So,
Can I ask a question about the weight? Is it an eating disorder, or like what's causing the malnutrition in a sense? Yeah.
Yeah, it is not entirely clear at this point. I think efforts to push into it have been really, this is not a patient who likes to talk, not engaged much, even with the providers who have most been able to connect with her. It seems that her pattern in particular of stimulant use when she's out of the hospital is very high volume and very chaotic, and that perhaps that's why she's just not eating. But I don't know that any of us could say with any certainty that there's not an eating disorder present that's sort of in this.
Yeah, because and just to add as a psychiatrist, like if there's an eating disorder and someone gains the weight, like doubles the weight in 4 weeks, that could be the sole reason of like, I'm not staying there. I'm like morbidly obese. I have to leave because I cannot tolerate that weight gain.
Okay, we're gonna soldier on. Patient comes back about 2 weeks after the last admission, complaining of really severe bilateral hip pain, essentially unable to walk at this point. She has this very large xylazine wound on her arm that is really unchanged. She now has a stage 3 decubitus ulcer over her ischium. X-ray and bone scan showed severe bilateral hip osteonecrosis. Orthopedics says the treatment would be total hip arthroplasty. She is not a candidate for this. She gets quickly titrated up to methadone 90. She's getting hydromorphone 6 milligram IV pushes, and actually manages to stay in the hospital this time for 2 weeks. Yay. Gets an aspiration of her hip effusion and accepts a dispo to a short-term rehab where she can continue to receive methadone. And so her dispo regimen to the short-term rehab is methadone 90 milligrams, hydromorphone, PO 10 milligrams every 4 hours, as well as oxycodone 20 milligrams every 4 hours for moderate pain. And so
And antibiotics.
yeah. And the methadone is going to be via OTP. So my question to Casey, you're on the receiving end of these scripts. What's going to happen with them? Is this going to work? Like, is it?
See, you ask a great question. However, knowing you would have reached out to me already. So I would be mentally and emotionally prepared to receive these prescription orders. To be on an outpatient setting, no, this is not going anywhere. You can get one, maybe two. I'll give you two. You get methadone and maybe pick one, hydromorphone or oxycodone, but you cannot get all three. Not me saying this, me as the insurance. You have to pick and choose your battles, and I will fight the good fight, and we'll try for the most ideal regimen first, and then if that doesn't work, then we can try for another one. But yes, unlikely that this will go anywhere. However, this patient is going to a skilled facility, correct? So this shouldn't be a problem.
Thoughts from the rest of the panelists?
My thoughts, because I just saw this happen, is someone went from the hospital to a skilled facility with 2 short-acting opiates for pain, and they never changed that. And then 3 weeks later, sent them home with 2 short-acting opiates that were not, in my mind, safe for the patient to have at home. And so I guess, the other robust communication, in addition to the pharmacist, is, who else doesn't have addiction consult teams is short-term rehab. So how are they supposed to, adjust the regimen as things change? And so we want to be able to have a conversation with their doc ahead of time around what is the plan, what's the stepwise plan for this person. And also their formulary may dictate that they get some version of this, but not exactly the same. And so you want to have that conversation too.
Can I add something? And with that, I was thinking, like, there's a lot of PRN medications, so the patient will need to ask the nursing staff for a lot of doses in a day, and also decide whether is it a moderate pain, is it severe pain, is going to be some resistance there. So the thought crossed my mind, so like just averaging what the patient was getting of the oxycodone per day, and like having a chunk scheduled and less basically as a as like that decision making on the staff's end and.
Yeah. And I think that's a really great point as well, because, you know, clearly the open communication is a barrier for sure. And having to ask for help, you know, is a challenge. And so, you know, really minimizing this also from like, just like a clinical staff standpoint, this regimen is not going to work. There is more than one patient on the floor. You know, and it's also going to be hard for pharmacy too, although granted they probably have a fixes machine and all these things, so maybe easier, but you know, ideally, like you were saying, averaging out the immediate release options and kind of going from there, maybe just schedule them. But definitely a lot of communication, both with the facility itself and, you know, just staying in contact with them, updating that regimen, but also communication with the patient. In this particular patient, it seems that when some of those expectations are set ahead of time, this is what you're going to be able to get, this is what we're going to be able to do for you when you go to this place, she may stay a little bit longer. And so, you know, if we're able to follow through on that, would be helpful.
That's a really interesting point about expectations and being able to honor explicit and implicit expectations for patients. I don't know anything about the patient, but I'm guessing she's probably experienced some pretty severe trauma in various forms in her life. And I think one of the most important trauma-informed principles is to be careful about what you promise to people and to ensure that you can really follow through on the things that you say are certain. And that can be really hard with meds like this and with transfers of locations of care. Just looking at her med list, I mean, I assume she's getting the Dilaudid every time, not getting the oxycodone. So there is a lot to be said for putting something standing, a hold parameter for sedation. Then the other thing, just looking down the line, assuming she's probably going to need to bump that methadone dose with time as the Dilaudid probably comes down, but that's probably going to be a really long taper at best. Yeah.
The other thing I'd say about this point in the scenario is that the disposition from hospital to short-term rehab and then eventually to home is often one where people or plans get lost. And so this is the person where whatever your mechanism is, just come up with something, but like scheduling a telemed with the intended PCP while they're still admitted at the short-term rehab. And then that PCP can like look at the discharge summary, see what the plan is, see what needs to happen next, like that. And they're probably not going to get paid for that, but in this scenario, that seems like fine. So that's one thing. And then the other is we still haven't treated her Hep C, and she's now been in our care, you know, for almost a month, it seems like on this slide, you know, and the patient whom I have who is most similar to this person, the treatment of her Hep C, I am not going to try to tell you that it cured her orthopedic problems, but boy, was her body able to heal itself better after her Hep C was treated. And it kind of, as I read through this case, I just felt like, you know, in addition to the malnutrition and the despair, we also had this untreated systemic virus that we could treat.
Right. And she's just kind of like sitting here hanging out, doing a coloring book and could just like take an up close-up with that. Yeah. Okay. 4 minutes left. So we're going to speed a little bit. Patient actually goes to the hospital about 2 weeks after the last admit. She ended up leaving the short-term rehab about 5 days after being there. She felt that they didn't really have good PT. She had ongoing pain. She stopped methadone and was using fentanyl at that point. Her decubitus ulcer is now stage 4. Her arm ulcer is still bad. And today actually called EMS to come back because she realizes a long hospital stay might be her only way to get a hip replacement, which she states is now her goal. So in terms of like where she is in terms of kind of what she wants and what she needs, she seems to have made a big change. And so what happens, she ends up hospitalized for the next 7 weeks. apart from a single self-directed discharge for 2 days because our hospital ran out of hydromorphone. She used it all. We got more. It's fine. She was like, I'll come back when you get more. She ended up having MRSA bacteremia secondary to the arm wound, and likely sacral osteo. She completed 6 weeks of Benko, and then ID said that she needs to be on lifelong doxycycline because of the extent of the bone disease. Her hip osteonecrosis was worsening and now has right femoral head collapse. Ortho is continuing to follow, but they still want her to gain some weight and have a bit more stability before they put any implanted thing in there. She actually gains 20 kilos during this hospital stay. Her nutrition improves really pretty dramatically. Lots of things happened with her methadone, as one might imagine. She was initially split dosed and titrated to 53 times a day, ended up consolidating to 135 in the morning, 15 as a PRN, which she took most days. And then for pain, she was getting Oxy 20 with some sort of strict guardrails on how much she could get and when she could get it. And again, that was via a lot of trial and error. Many other things were trialed, and she was really willing to engage with all those trials and stay with us. She also trialed a bunch of other things that didn't really do much for her, but she was willing to trial them for us. The other things that really helped: newspaper every day, coloring books, being allowed to smoke, and chocolate Ensure, which is in every single one of Natalie Stahl's notes. First line in the A&P, give her chocolate Ensure, which she really appreciated. And so we're now sort of starting to discuss her disposition. Her home is a 3rd floor walk-up. She has really been declined by most short-term rehabs. She's been to a lot of them. She's okay with the Shattuck, but they don't really have any beds at the moment. And she's got planned for a direct admit to, it was Brightview then, with a VNA for home dosing once she was out of short-term rehab. VinFen has now been involved and is going to help with some transportation. And there are obviously anticipated concerns regarding pain medicine. So final thoughts, we're going to abbreviate the case in the setting of time, but thoughts on where we are and where we're going.
Can I say something? So what I've noticed, like, so she's not engaged with you guys. She leaves and then she stays longer and longer. And then she goes to another place and leaves because PT is not good. So for me, like, I'm with you on probably the history of trauma, and she actually learned that she can trust you guys. And that's probably was behind like coming back and actually staying for 7 weeks, because there are new people who didn't know her that well and didn't trust them. So it just like that emphasizes probably like psychiatric need, like for PTSD, because I'm sure that speaks for that. And then also just like how you put it in the slide, like the newspapers and the smoking, right? Like how many patients don't leave the hospital because they're not allowed to smoke. But here it's like life and death situation. In a sense, like, can we allow that, right? And how important, I personally, as I was in residency training, I picked up many arguments with nutrition over like, I asked for chocolate and sure you send it. Why it's a strawberry one, like how many times it's important. Like something like, yeah, it hurts.
Does she have a PCP? Like, did she connect with a resident and now she has a PCP, or?
She does.
Okay.
Yeah, she does.
Okay.
Yeah, and so I think that's also been part of it, is like relationship building while in the hospital, and she's going to continue with one of the addiction consultants from in the hospital in the outpatient setting. That was really important for her. Yeah.
Oh yeah. Oh yeah.
Okay, cool. So that is,
Hand
oh
down.
yeah, we're actually going to go to Q&A right now. So if folks have questions for any of our panelists, please come on up.
Yeah.
Hi. Go ahead. No, you. Okay. Yeah, I'm Chris from BHN. This is a question born of pure ignorance, so I apologize. But if we go on like the Wayback Machine to when it was mostly the upper extremity pain, like what would be the pros and cons of like maybe a nerve block for somebody who has like sedation issues and like soft BPs and stuff?
It's a great question.
Yeah, I mean, I think very reasonable to offer to a patient in a situation like this. I think the question is always a little bit like how much of the pain is being treated by the opioids and how much of it is just like really high levels of opioid tolerance and need for ongoing agonists to be able to stay, which I think is something we kind of eventually figured out with this patient. And then I think also what is the availability of anesthesia in your setting to do things like that? Like this is a community hospital that's not particularly well staffed by anesthesia. And so if they have, you know, a break between cases, they might be willing, but otherwise, who knows when it'll happen kind of thing. But yeah, I mean, I think thinking outside the box, right, is absolutely the right thing to do. And it was always a little bit hard. This is a patient who I always found it a little bit challenging to predict what she was going to like or not like, you know? And so just offering more things and seeing what sticks is like definitely a way sort of around that, right?
I think in the early days when those hospitalizations were only like 2 days, the ability to get anesthesia to come in, consult, advise, then make time for the elective procedure, like it's just the hospital's just like not able to do that. You know, it's just
Right. They're all going to
unfortunately,
want like
we're not
negative blood
nimble.
cultures for 48 hours and like maybe they'll always be positive anyways. Yes, over here.
Slosakov, Lynn Community Health Center. Is this working? I actually want to pick up on something Liz said and not just because she.
Actually, yeah.
But it's more of a statement than a question, really. And we've seen, not only does Hep C improve patients physiologically, but I know I've published, but it's not just me. There's other publications now demonstrating that people who in addiction care who are treated for Hep C do better in their addiction care. So in terms of self-efficacy, it's a mastery moment. And it, you know, not when she was deathly ill, but we've been seeing her for months now. And it really could have been a mastery moment for this patient to cure her Hep C. And, you know, it would have been a gift. So I agree with you.
Love that. Over here.
Hi, Elizabeth Langmore with BHN in Holyoke and Springfield, OTPs in psychiatry. So of course I'm thinking as a psychiatrist, in addition to the pain management, and as you say, the hospital setting being a community hospital, I'm not sure if there is availability of a psych consult because that would obviously be a huge part of management, the concurrent PTSD. Apart from that, I'm wondering how, the way that the patient presented initially, what about a role for a section 12 in terms of like gross inability to care for self? I mean, if she really, just the information made me envision someone who is literally about to die. And so, you know, obviously patient autonomy is exceedingly important. But in that situation, I feel like it could have been a discussion. I don't know if that was something that would have been available or appropriate.
I think at that point, though, you have to also think about after you do that, then what, right? Because then now, especially in a patient who very much values their autonomy, you know, you were the only kind of somewhat consistent person that they somewhat trusted in the healthcare system. And now you've broken that because you've forced them to stay somewhere that they didn't want to be.
And I've had to do that, and it's a terrible decision to have to make. It's just, I don't know, but I feel like it's probably, it's on the table as something to be thinking about.
Mm-hmm. Yeah, I think, right, like that discussion of like, you know, in her case where I don't know that she necessarily was endorsing like self-harm, like maybe not section 12, but potentially section 35, you know, for ongoing, you know, sort of very chaotic and dangerous drug use. I'm sure it was discussed. I think ultimately felt not to potentially be of benefit for her in the end. Yeah.
Hi, Talia Singer-Clark, BHN and BMC. My question was about the methadone titration, and especially in the early admissions when she was leaving and coming back every few days, was she then having to start over and then get up to the 90 or 100 that she seemed to sort of top out at? Or was she like, if she's only gone for 1 or 2 days, was she then starting at 100 again and able to go up from there? Or was she always having to titrate back up?
Yeah, I think it transitioned a bit with our hospital's comfort with methadone. I think initially she was going back down, but also was never really getting very high anyways. So, you know, she got a single dose of 20 and then she left. And so the next day she got another single dose of 20 when she came back for a second admission. But as the hospital's comfort with like not dropping her all the way back down, right? Like she left yesterday and had been on 80 and comes back 2 days later and is fully awake and totally fine. Like, great, we're just going to give her 80 again, right? And we're going to continue the titration. And that ended up, I think, in the end being how we got her to reasonable doses at all. Because yes, at the beginning it was very hampered by that. And the degree of, I think, as we learned this morning, methadone is like the land of everybody saying like, this is the law, this is the rule, but like nobody actually knows. And it's like maybe all fake, right? And that was like very much the case in our hospital when this case started. Like people felt so strongly that they knew the ins and outs of every law about methadone and it was all made up. It was all made up, right? And so as time went on, right, and I think people on the floor started to see cases like this of like, she's not gonna die. She's actually gonna be fine. You know, like everybody just calm right down. She's breathing. Like, you know, she just doesn't want to talk to you, right?
My other question was, and I guess kind of for everybody, has anyone had success discharging these patients on a split dose of methadone to a short-term rehab? And if so, which one?
Yeah.
No, not in our area. Katie, last
Heidi,
question.
that's a human rights issue, and I'm happy to fight it. So what I was going to say, though, is I recently read an article in one of our publications talking about how this patient, had she been hospitalized in Canada, could have been in a facility that had an opioid prevention center within the hospital setting. And so she actually could have had the choice to use on top of the treatment, but remain in care. And as I was hearing this case, I was thinking about what would the outcome have been better, different, or otherwise? And so I just wanted to put that out there, is that this case would be so different in another country where she didn't have to leave to meet